Thank you for your attention, and thank you for giving me the opportunity to present here at the great meeting. My name is Caroline Espersen. I'm currently a first-year resident from the University of Copenhagen, and I'll be presenting my work as a Fulbright scholar at the Brigham and Women's Hospital, Harvard Medical School. And the paper is entitled Sex Differences in Congestive Markers in Patients Hospitalized for Acute Heart Failure. So, several sex differences have already been reported and investigated in patients with acute heart failure, some of which are depicted here. However, we do not yet know how these differences relate to differences in congestion between women and men with acute heart failure, in particular pulmonary congestion. Pulmonary congestion is a cardinal finding in patients with acute heart failure, and lung ultrasound is a useful tool to both detect and quantify pulmonary congestion. In light of this, lung ultrasound has also proven useful for the diagnosis, in monitoring, and prognosis in patients with acute heart failure. And because of this evidence, lung ultrasound has also been included in the 2021 ESC guidelines for the diagnosis and treatment of acute heart failure. However, we do not yet know if there are any differences between women and men in lung ultrasound findings in patients with acute heart failure, or whether sex-specific cutoffs are needed. So, in this study, we sought to first investigate sex differences in congestive markers based on physical examination, chest X-ray, echocardiography, laboratory tests, and lung ultrasound at baseline in patients hospitalized for acute heart failure. Second, we wanted to examine sex differences in the dynamic changes in congestive markers during a hospitalization for acute heart failure. And lastly, we sought to assess the prognostic value of congestive markers at discharge on the composite 90-day outcome consisting of heart failure hospitalization and all-cause mortality in women and men. So, this was a post-hoc analysis of the two-center prospective observational study in adult patients hospitalized for acute heart failure at two academic hospitals, one in Boston and one in Glasgow. On admission, patients had a baseline lung ultrasound performed. At the same time, they also had an echocardiography performed. Then they also underwent a physical examination, had laboratory tests taken, including NT-proBNP. And if clinically indicated, they also had chest X-ray performed. And then the patient-reported dyspnea was also recorded on admission. Then, prior to discharge, a subset of patients had a pre-discharge lung ultrasound performed. They also underwent a physical examination again, and the patient-reported dyspnea was recorded prior to discharge as well. Then we followed the patients for 90 days and looked at a 90-day composite outcome consisting of heart failure hospitalization and all-cause mortality. And these events were adjudicated by experienced physicians at each site. Yes? Can you skip the next slide?
How's it going?
No. Well, stay tuned for the lung ultrasound images. The one after. What I was going to show you was the lung ultrasound protocol used in this particular study. Because we used an 8-zone protocol and a simplified 4-zone protocol, and that's what I wanted to show you examples of here. Because the simplified 4-zone protocol only includes 2 zones in each hemithorax. So it's a more simplified version of scanning up to 28 zones. But we'll be able to show you.
Who performed the ultrasound?
The ED physicians.
The ED physician.
But they had an experience in lung ultrasound, so they had to have at least a few years of experience. Okay, we can see. There you go. So this here on the left is the 8-zone protocol. And then we have the simplified 4-zone protocol. And these were the lung ultrasound protocols we used in this study. And the lung ultrasound images were analyzed offline by experienced operators blinded to clinical findings and the timing of the lung ultrasound. Yes, you can change. Yeah. So then if we take a look at the baseline clinical and demographic data in this cohort, we found that women were older. You can click. They were older, they had a lower BMI, higher systolic blood pressure, and more often presented with heart failure with preserved ejection fraction. In contrast, men more often had a history of prior heart failure hospitalization, and more often had a history of ischemic heart disease. Yes, and if you then take a look at compare the congestive markers at baseline between women and men, we found that women reported a higher degree of dyspnea at rest at baseline, whereas men more often presented with lower extremity edema. However, there were no significant differences in the other physical examination parameters between the two groups at baseline. Based on the baseline chest X-ray, there are also no significant differences between women and men. Likewise, there are no significant differences in the NT-proBNP levels between women and men at baseline. However, the baseline echocardiography revealed significant differences between women and men. Overall, men had worse left and right ventricular systolic function, whereas women had higher measures of filling pressure. Lastly, if you take a look at the lung ultrasound and compare them between women and men, we found that there were no significant differences in the number of B-lines, both based on the 4-zone and the 8-zone protocol at baseline. Then we looked at the dynamic changes in the congestive markers from baseline to discharge in women and men. And we found that there was an improvement in the dyspnea score at rest from baseline to discharge in both women and men. Likewise, there was a reduction in the supplemental oxygen demand, a reduction in the number of patients with jugular venous distension of more than 10 centimeters in both women and men from baseline to discharge. In men only, we also found that there was a significant change from baseline to discharge in the number of patients with crackles and leg edema. If we then take a look at the lung ultrasound findings and compare them from baseline to discharge in women and men, we found that there was a similar and significant decrease in the number of B-lines from baseline to discharge in both women and men. And this was consistent for both the 4-zone and the 8-zone lung ultrasound. We also found that a higher number of B-lines on the 4-zone lung ultrasound prior to discharge was associated with an increased risk of the composite 90-day outcome consisting of heart failure hospitalization and all-cause mortality. And we found this in both women and men. In men only, a higher number of B-lines in the 8-zone lung ultrasound was also associated with an increased risk of the composite 90-day outcome. And these are univariable analyses. So in conclusion, we found that echocardiographic markers differed between women and men at baseline, whereas the number of B-lines in lung ultrasound did not, thus suggesting that we may not need sex-specific cutoffs for lung ultrasound findings in patients with acute heart failure. Second, we found a similar and significant decrease in the number of B-lines from baseline to discharge in women and men, thus suggesting that women and men responded equally well to therapy during this acute heart failure hospitalization. And lastly, we found an increased risk of the composite 90-day outcome with a higher number of B-lines in the 4-zone lung ultrasound prior to discharge in exploratory analyses in both women and men. And for those of you who are interested in reading more, the paper is now published in ESC Heart Failure in 2021. So thank you for your attention.
I see we already have a question on the floor.
Great job. I'm a big supporter of lung ultrasound. Two questions for you. Was the pre-discharge lung ultrasound available to the clinical team, or is it blinded?
It It was blinded.
Okay.
Yeah, so it wasn't used in the clinical decision making.
Okay. What are your thoughts about using this? Should we be targeting B lines rather than NT-proBNP, JVP, et cetera, with our therapies over those 5 days in the hospitalization?
Well, I think it should be included as part of the evaluation. As lung ultrasound is it's readily available, it's portable, it doesn't expose the patient to any radiation, and it's easy to use, fast, so I think it should be implemented as part of the diagnosis in patient with acute heart failure. And it could also be used as a monitoring tool, also perhaps to guide the diuretic treatment, because now it's based on urine output, physical examination parameters that aren't always as sensitive. So using lung ultrasound might be a better and more objective way of targeting therapy.
100% agree. What are your thoughts about the lag of diuretic therapy and B lines? You know, how long should you be treating someone before you see a change or don't see a change and you think you need to ratchet up your diuretic therapy?
That's a very good question. Well, if you monitor it over time and you see a reduction in the number of B lines, then that's how you should use it. Yeah.
Thank you, Caroline, for this wonderful presentation. I have also one question. Oh,
Thank you very much for your presentation. My question is a fast question. The first lung ultrasound, was it done before acute therapy was in naive patients or after therapy of acute heart failure?
So the lung ultrasound was done within 1 day of admission to the hospital. Yeah. Yeah. Any further questions?
yes, well, I have one question. You showed that the women had a little bit better ejection fraction than men do.
Yeah.
How can you explain that?
Well, it's consistent with the literature that women more often present with heart failure with preserved ejection fraction, and they had more higher filling pressure, so they were more likely to have diastolic dysfunction, which is also consistent with literature in patients with heart failure and acute heart failure.
Perfect. Yeah, there is one more question.
Sorry, but I would like to remark on this topic on ultrasound evaluation in patients with acute heart failure in the emergency room. I think that Sean is absolutely right, and if you look carefully in the guidelines, they are absolutely recommended, even more than too much do echocardiographic assessment in sophisticated evaluation. So, and we publish as a acute cardiac care group a paper, position paper in European Heart Journal showing that what is important to standardize the evaluation. So it is not the problem to do or not to do, but also to do properly. So I would like just to leave an important concept. We should do lung ultrasound, which is much, much easier than the echocardiographic assessment, waiting for the new device for intelligence, artificial intelligence. But what is important to follow our guidelines, how to perform, to standardize. So at the end of the day, you do natriuretic peptide, you do echocardiographic, just left ventricular function and right ventricular function vena cava. It's it. And then you do ultrasound. That is going to link it with wage pressure. But I think this is a message that we can discuss open probably in the future, but it's something I would like to discuss with the young fellow and the specialist in echocardiography to understand what is the value, big value of lung ultrasound in the emergency room, different from a lab where you do echocardiography, you can have 1 hour to do that. Sorry to make this comment, but this was important.
Yeah, thank you.
Any more questions from the floor? I have one quick question. Did you see a difference in the baseline characteristics regarding diuretics upon admission?
No, there's no,
No.
significant difference in
No
the
difference.
diuretic treatment between women and men at baseline.
On what they were already taking?
Yeah, on what they're already doing.
Okay. Thank you very much.